So, good morning, everybody. I am here to talk on the combination therapy, the DPP4 inhibitors and SGLT2 inhibitor in combination. How good is this combination as far as the diabetes is concerned? How good is this combination as far as many diabetic complications is concerned? Especially, we are very concerned about the cardiovascular disease, and we have to see whether this combination therapy has any beneficial effect on the cardiovascular outcome and how good it is as far as the glucose control is concerned. So, with this small introduction, I will I'll go into the recent guideline, what we usually follow in our day-to-day clinical practice. And you can see this was published in 2018 by American Association of Clinical Endocrinologists. And this guideline shows that this SGLT2 inhibitors and DPP4 inhibitors are a very, very important choice in front of us. We can use it just after metformin therapy. We can use it as a monotherapy also. And especially among the patients who are having HbA1c more than 9%, we have to start with a dual therapy or triple therapy. And in those situations, the combination of SGLT2 inhibitors and DPP4 inhibitors are a very, very important choice in front of us. So we can start this combination after the metformin therapy. In majority of the situation, we do start this therapy after metformin therapy. But in some of the situation, we can start all the three together from the very beginning. So the combination therapy is available in 10 milligram by 5 milligram dose combination, EMPA plus LINA, or it may be available in 25 milligram and 5 milligram combination, as EMPA plus LINA. So these are the two important tablets we have of two different strengths. And we have to check whether the combination, when we combine these two drugs, whether they actually interfere with the bioavailability of the other one or not. So this is an important study which has looked into the PK/PD of the linagliptin and empagliflozin when it is given in combination. And this important publication has confirmed that the bioavailability and bioequivalence, that means the PK/PD of linagliptin and empagliflozin, are not affected by the co-administration, and therefore this combination have no drug-drug interactions, and therefore they are quite safe, and we can expect to have the benefits from both from the drug in combination as well, the way we receive the benefit when we advise the drug separately. Now, with this introduction, we will look into the complementary action of the combination therapy. We also will look into the glycemic benefit. I'll show you some cases. Then the cardiovascular benefit of this combination. Then some pleiotropic benefit which we can expect out of this combination. And then we will talk about the concern with this therapy. Now, what are the precautions we should take while we start this combination therapy or when we are giving this combination therapy, and then I will conclude. So let us have a look into the complementary mechanism of action of these two drugs. We all know that the diabetes is basically have multiple pathophysiology, and nowadays we talk about the 8 different pathophysiologic defects. And you can see that the pathophysiologic defect is not restricted to beta cell dysfunction and the insulin resistance, but it has expanded into the alpha cell defect, into the kidney, the excess amount of glucose reabsorption. It may be an incretin defect, which is there in the gastrointestinal tract. So these all together roughly comes around the 8 defects, and we can consider it as homogeneous octet, as it was basically proposed by Franzo. So if we look into the combination therapy, that the DPP4 inhibitor and SGLT2 inhibitor, when we give it in the backdrop of the metformin therapy, we find that almost all the defects are actually addressed when we give these 3 drugs. So usually we use most of the situation the combination therapy after the metformin failure, or as I've told you, sometimes we use all three drugs together from the very beginning. So if when we give these three drugs or together, then we expect that almost all the pathophysiologic defects of the diabetes mellitus will be addressed. Now, this is a very important understanding, which was basically proposed by DPP4i about 10 years back, but it is yet to percolate into the mind of the treating physician that we have to start all many drug or multiple drug from the very beginning. So he says hit early, hit hard. It means as because the type 2 diabetes mellitus is basically a defect of multiple pathophysiology. So we should give a combination drugs, multiple drugs, which come in combination will address the multiple pathophysiologic defects of the diabetes. And therefore, from the very beginning, if we start with multiple drug and if we actually hit them hard and early, then it will have a beneficial effect in the later part of the life. So actually the proposal is to deviate from this staggered therapy into the combination therapy from the very beginning, and it has also there are relevant evidences to show that this approach will be very beneficial as far as the diabetes and its complication is concerned. So so let us have a look into the complementary action of these two important drug combination. One of the very important complementary action is the glucagon secretion. If we look into the SGLT2 inhibitors, they actually increase the glucagon secretion. On the other hand, the DPP4 inhibitors actually suppress the glucagon secretion. Increased glucagon secretion has a contributory effect to the hyperglycemia. So when we give DPP4 inhibitor, this glucagon secretion is suppressed, and therefore these two drug combination actually have very complementary action as far as the hyperglycemic state is concerned. Apart from this important area where actually the DPP4 inhibitor help in reduction of the glucagon secretion, which is aggravated by SGLT inhibitors, in all other areas you can see that these two drugs have a very complementary action, because they in combination increases the GLP-1 level. The DPP4 inhibitor mostly act on the beta cell, though it has got some other action as well. But SGLT inhibitor action is basically beta cell independent, so therefore their mechanism of action is different. So therefore it has got a complementary action as far as the glycemic benefit is concerned. Now coming to the glycemic benefit, when we give the combination therapy, how much we expect the A1C will go down. So that expectation should be in our mind when we start with the combination therapy. Now let us have a look into this patient, a 38-year male patient, asymptomatic and diabetic for the last 2 years. He was 69 kg in weight, BMI 26.9, and he is on metformin therapy twice daily, 1 gram. And his H1C level is quite high, 9.4, and fasting is 255, and PP is 360, and blood pressure is normal, EGFR is normal, and therefore the patient is basically uncontrolled on metformin therapy. Now, what should be our choice? Now, if we look into this patient, then this patient is quite young, having diabetes only for a short duration of time, say 2 years, but the glycemic control is very poor. If we think that we add one agent, whatever agent you are considering, the one agent will not bring down the H1C from 9.5% to the target range of 7 or 7.5. So we have to act more aggressively from the very beginning. We just cannot give one drug, wait for the drug to fail and then add another. Rather, from the very beginning, we have to give a combination therapy or 2 or 3 more agents simultaneously, so that we can quickly bring down the H1C to our target. Now, let us have a look into the benefit of the combination therapy. Now, this is an important study which has been done, which is done after the metformin failure. Then the empagliflozin and linagliptin was added as a second-line agent. And this trial, you can see that they have compared the combination therapy, empagliflozin and linagliptin, along with if we give the empagliflozin or linagliptin separately. So if we look into the result of the study, you will find that as expected, the combination therapy will give more benefit as far as the H1C reduction is concerned. And if we give the either of the agents separately, it will produce less reduction in the H1C. So after the 3 months period of time, so 12 week, you can see that we can expect a significant reduction in the H1C when we give this combination therapy. And another important understanding is that if we continue with this combination therapy, the H1C level remains within the target range for a long period of time. The study has been done more than 1 year, and therefore we expect that that the durability of the action of the combination therapy is quite long, and therefore after starting the therapy, we expect that this combination therapy will have a long-lasting effect and can keep the H1C within the target range for a long period of time. Apart from this, if we actually compare the H1C reduction with the combination therapy with that of each agent separately, will find that the combination therapy have reduced H1C to the range of more than 1%. And if we give one agent separately, then the H1C reduction is less than 1%, 6.6% or 0.7%. But at the same time, the another understanding we have that if we start with a very high H1C, then the H1C reduction will be more robust compared to when we start with H1C level less than 8.5. So this study also showed that if we start with more than 8.5% of H1C, and in our case also have H1C more than 8.5, and here we can find that H1C reduction is more than 1.5% when we give the combination therapy. So therefore, we can expect a very robust H1C reduction when we start this combination therapy in our patient, because our patient has H1C more than 9%. At the same time, we can have another important beneficial effect is the weight reduction. As you know, if we give empagliflozin, it is associated with weight reduction, and most of our diabetic subjects are either overweight and obese. So therefore, the administration of empagliflozin is actually beneficial as far as the weight is concerned. So we also looked into the Asian subset, and this combination therapy is almost equally effective when we look into the Asian subset as well. So therefore, not only the study was done in the non-Asian subjects, but a subset analysis on the Asian subject was also done to show that this combination therapy is equally beneficial in the Asian subjects as well. So therefore, coming back to our own publication, which we have looked into the administration of SGLT2 inhibitors on the existing therapy with DPP4 inhibitor and metformin. So all the patients who are receiving DPP4 inhibitor and metformin, and we have added SGLT2 inhibitors over and above DPP4 inhibitor plus metformin, and we found that there is an H1C reduction roughly around 0.7%. So with this understanding, let us go back to our patient, and you can see that this patient was started with the combination therapy, and on the first visit when the H1C was 9.4%, was reduced to 7.9% after 1 month period of time, and you can see there is a significant reduction in the fasting and PP blood glucose level as well. So therefore, we expect over a period of another few months' time, the H1C level will go down further, because this H1C was done on just after 1 month period of time. It may not have it may not give you a complete picture or the complete reduction of the H1C. So we expect that after a few months therapy with this combination, the H1C level will go down further. Another interesting aspect of this combination therapy is that neither of these two drugs actually cause hypoglycemia. So even if the blood glucose level was significantly down from 255 fasting to 121, we don't have to worry about the hypoglycemia, because neither the metformin nor the DPP4 inhibitor or linagliptin or not the SGLT2 inhibitor, that is empagliflozin, is associated with increased possibility of hypoglycemia, and therefore we can safely administer these three agents and we don't have to worry about hypoglycemia as far as this important combination therapy is concerned. Now let us come to the cardiovascular disease and the combination therapy, which is a very, very important area of when we discuss about this combination therapy. Let us have a take a look into this patient. This is a 53-year-old man with type 2 diabetes mellitus for the last 3 years. He had a myocardial infarction 4 years back and hypertensive and dyslipidemia. We often say this kind of patient. The patient is basically a smoker, had a peptic ulcer disease, and now receiving metformin, ramipril, bisoprolol, atorvastatin, and aspirin. The question is that this patient actually have a gradually deteriorating weight gain, and there's 4 kg weight gain occurred in the last 12 months. There is a gradually deteriorating glycemic in the last 1.5 years. He has poor sleep. There is a snoring because of the possibly sleep apnea syndrome. The weight is 93, BMI is 33, H1C is poorly controlled, 8.7, and there was fasting and PP blood sugar level was also very high, but the GFR is quite maintained. The question is, what is the next best step in front of us? The issue is that the glucose control is not good. The patient has got a body weight is quite high, and third is that the patient had a myocardial infarction in the backdrop. So when we look into this kind of patient, it is very, very important that we should choose a drug which will have a beneficial effect in all aspects of morbidity. Then not only we have to address the glycemic control, but we also have to remember that we are dealing with a patient who have myocardial infarction in the backdrop, and the patient who are quite heavy as far as the weight is concerned. They are 93 kg body weight. So if we look into the EMPIRIC trial, which has actually studied, let us have a look into the inclusion criteria. You can see that they have included type 2 diabetic subjects with BMI less than 45, H1 is 7 to 10%, and who had established cardiovascular disease. One of them is prior myocardial infarction. So this classically fits with our patient. Now you can see our patient is basically a type 2 diabetic. This patient has got a BMI less than 45. This patient has got a H1C between 7 to 10, and this patient has got a prior myocardial infarction. So this patient perfectly matched with this criteria as far as the EMPIRIC outcome trial is concerned. So whatever the benefit or the problem faced with this EMPIRIC outcome trial is expected to happen to my patient also, because they fit with the inclusion criteria of the EMPIRIC outcome trial. Now, if we look into the cardiovascular outcome issue, then we will find that the 3-point MACE was very, very statistically reduced as far as this important study is concerned. Now, why why there is a significant reduction in the 3-point MACE, that is cardiovascular death, non-fatal MI, and non-fatal stroke? The most important is in the reduction in the cardiovascular death. So if we give this combination, if we give the empagliflozin, then we expect that it will significantly reduce the cardiovascular death among the patient. So there is not only the cardiovascular death, which is reduced by 38% in the EMPIRIC outcome trial, we expect a 35% reduction in the heart failure. As you know, heart failure is a very, very important cause of morbidity and mortality among type 2 diabetic subjects. Almost 8 to 10% patients who develop heart failure and hospitalized. Among the hospitalized patients, 8 to 10% actually die. So therefore, heart failure is a very, very important cause of mortality among type 2 diabetic subjects. So this heart failure, hospitalization for the heart failure is reduced by 35% when we give the empagliflozin. And very, very important outcome is the all-cause mortality. It means whatever may be the cause of death, if we give empagliflozin, there is a significant 32% reduction in the all-cause mortality. So therefore, this is a very, very important drug. When we use in the backdrop of cardiovascular disease, we expect that not only it will give a benefit as far as the glucose control, but it will also give a significant benefit as far as cardiovascular disease is concerned. Now let us have a look into the cardiovascular aspect of linagliptin. This is a This is basically the Carmelina trial, and you can see that there are two trials actually was conducted on linagliptin, and one is Carmelina and another is Carolina. Carolina was actually compared with an active comparator glimepiride. And if you look into the Carmelina, I'll especially focus on Carmelina because you can see that the Carmelina study was conducted who had majority of them have had a cardiovascular established cardiovascular disease 57%, and very high percentage of the patient have the renal disease as well 74%. So let us have a look what happened to the patient who have joined the Carmelina trial, who had significant cardiovascular disease and significant amount of renal disease in the backdrop. And you can see that the results show that the linagliptin is quite safe as far as cardiovascular disease is concerned. It has got no beneficial effect. It is not doing any good, but at the same time, we have to remember it is not doing any harm. If we compare with the placebo, then the linagliptin is as safe as placebo as far as cardiovascular outcome is concerned. So it is not doing any good, it is not doing any harm, but therefore it has got a neutral effect as far as 3-point MACE is concerned, that is cardiovascular death, non-fatal MI, and non-fatal stroke. And if we look into the all-cause mortality also, the linagliptin again have a neutral effect, just like a placebo, so it don't have any effect as far as all-cause mortality is concerned. And if we look into the risk of hospitalization for heart failure, which is a very, very important concern, as far as the heart failure is concerned, because we have seen some of the DPP4 inhibitors are associated with increased possibility of the heart failure. So this important trial has actually showed us that the linagliptin is not associated with any heart failure issue, and therefore it can be used very safely in the patient who have cardiovascular disease in the backdrop. So looking into this, the standard of care advice, this is 2020 guideline. You can see that if the patient have got a significant cardiovascular disease, atherosclerotic cardiovascular disease in the backdrop, it is recommended you should use a drug which have proven benefit as far as the cardiovascular disease is concerned. The two important choice in front of us is either the GLP-1 receptor agonist or an SGLT2 inhibitors. So these are the two group of drugs which actually have proven benefit as far as the atherosclerotic cardiovascular disease is concerned, and therefore we have to choose between the two. But you know that the GLP-1 receptor agonist therapy is basically injectable, is much higher cost, and in many cases is associated with significant upper GI problem. So therefore it appears that the SGLT inhibitors is quite safe and quite tolerable, quite acceptable to the patient as because it is a tablet, it is not an injection, and we can expect a significant benefit as far as cardiovascular outcome. So therefore majority of the patient actually prefer SGLT inhibitor than GLP-1 receptor agonist, but we have two choice. So you have actually two choice. You can choose either of the two, or you can discuss with the pros and cons of the two drug with the patient, and you can advise either of the one. Now, in the backdrop of heart failure and the kidney disease, then you can see that again we have the two important choice in front of us. That is either you to give the SGLT2 inhibitors, or we can use the GLP-1 receptor agonist therapy, because both of them was shown that they have some beneficial effect in the heart failure and the kidney disease. So if we look into the patient who have atherosclerotic cardiovascular disease, in whom you have started the SGLT inhibitors, and if the patient is not controlled with SGLT inhibitor, the next drug of choice is basically the DPP4 inhibitor if the patient is not on GLP-1 receptor agonist. So therefore, if the patient on SGLT inhibitor, not on GLP-1 receptor agonist, if you want to add the second agent after the SGLT inhibitors, the best choice is the DPP4 inhibitor. So coming back to the same issue, that when we are looking for the cardiovascular disease, and then we should start either the SGLT inhibitor or GLP-1 receptor agonist. And if you find that the patient already have a very high glucose level, and if you want to give both the SGLT inhibitor and the DPP4 inhibitor in combination, then this combination therapy is a very good choice in front of us. So coming back to the patient, so this patient was basically diabetic for the last 3 years, had a myocardial infarction, the BMI was 33, and the HbA1c was 87. So we preferred that we should start with a combination of empagliflozin and linagliptin 10 by 5 milligram dose combination. Coming to some of the pleiotropic benefit which we can expect with the use of this combination therapy, let us have a look into this another patient, a 40 years male. He has diabetic for the last 2 years, and there was a weight gain of 6 kg in last 1 year, and weight is now 92, BMI 32, and current medication is metformin 1 gram twice daily. The HbA1c is 9.1, glycemic control is poor, but very importantly, the patient have ACR more than 300 milligrams. So the patient is basically uncontrolled with the metformin therapy, but the patient have got a very high BMI, say 32 kg per meter square. Glycemic control is poor, and another important issue is that this patient has got a high ACR or albumin creatine ratio, indicating that the patient have a diabetic kidney disease in the backdrop, though the GFR level is around 63. So not very bad, but some degree of impairment. Now, if we look into the Carmelina trial, in again, as I've told you, that in the Carmelina trial, the 74% patient had the significant kidney disease in the backdrop, and this trial actually looked into the renal outcome among the patient. Now you can see that this Carmelina trial had shown that the favorable trend in the hard renal endpoint. You can see that their time to progression of end-stage renal disease or the death due to kidney disease was reduced with the use of the linagliptin therapy, and you can expect some reduction in the albuminuria progression also, 14% reduction in albuminuria progression when we give linagliptin therapy, and we can also expect the some kind of benefit in the progression of kidney disease with empagliflozin as well, though this the EMPIRIC trial was did not have the power to show the renal outcome, but this is some exploratory analysis has been done, which showed that the benefit of this drug is there as far as the progression of the renal disease is concerned. The new onset or worsening of nephropathy is basically reduced when we give empagliflozin therapy compared to the placebo, and when we look into the doubling of the serum creatinine with GFR less than 45, you can see that the empagliflozin is better compared to the placebo as far as this part is concerned. And if we look into the time to first initiation of continuous renal replacement therapy, where the empagliflozin also increases the time, and it is better compared to the placebo. So in the renal perspective, the linagliptin and empagliflozin both is associated with some beneficial outcome. And looking into the hard renal outcome, which is a composite of the doubling of serum creatinine, initiation of the renal replacement therapy, and death due to renal disease, if we combine all these three, then also the empagliflozin is better compared to the placebo therapy. So therefore, this combination therapy will have some beneficial effect as far as the renal outcome is concerned. So we have started this combination therapy. You can see that we are, as expected, we can see a significant reduction in the glycemic control, fasting, and BP blood sugar, and the HbA1c reduction. And at the same time, we find that there is some reduction in the albumin creatine ratio as well, from 321 to 128. That is also we expect to occur when we give this combination therapy, because there is a possibility that they will regress the progression of the renal disease or albumin or the proteinuria. At the same time, we get some benefit in the weight also. The 92 kg body weight came down to 87.3. So in this combination therapy has got a beneficial effect if the patient has got a backdrop renal disease as well. So coming to the concern with the combination therapy, now this is very important to remember that where we should not use this drug. Now, it is very easy to start the drug, but we should determine that where we should not use this drug. Now, this is the area which all of us should remember, that when you give this combination therapy have DPP4 inhibitors, and therefore we have to be careful about the pancreatitis. The relationship of the DPP4 inhibitor and pancreatitis is yet to be proved, but yet to be nullified. Therefore, we don't know whether it has got relationship or not, but majority of the study shows that there is a relationship exists, and therefore, whenever a patient have background history of acute pancreatitis, we should avoid this drug, because most of the guideline shows, or about most of the guideline gives us this important recommendation that we should not use this drug if the patient has got a previous history of pancreatitis. I must add another important point, that if a patient has got a renal stone, gallbladder stone disease or gallstone disease, then also we should be very careful as far as the use of DPP4 inhibitor is concerned, because because the presence of gallstone disease also increases the possibility of acute pancreatitis, and therefore it is possible you should be very cautious when you are giving DPP4 inhibitors in the backdrop of gallstone disease. Now, we don't have to measure the amylase and lipase level when we start the DPP4 inhibitor, but if the patient complains of pain abdomen, then we should stop the drug and we should measure the amylase and lipase to look into whether the patient has developed acute pancreatitis or not. Another important issue with DPP4 inhibitors is the joint pain. So this is a FDA warning that the therapy with DPP4 inhibitor can have severe joint pain, which we have to remember. And the third important issue is the bullous pemphigoid, the skin reaction, which can also occur in patient who receives the DPP4 inhibitor. So these are the three important points which we have to remember as far as the DPP4 inhibitor therapy is concerned. Now, coming to the SGLT2 inhibitor, because we have given empagliflozin, so we should be very careful about the side effects of empagliflozin. But the concern with empagliflozin, one of the important is that the diabetic ketoacidosis. Now, we have to avoid the catabolic state. Now, you know, there are many situations when the patient is in the catabolic state. Especially, I do not use this drug in the patient who are hospitalized or the patient who are in intensive care setup. So there is a possibility when the patient can develop diabetic ketoacidosis. We should not use this drug if the patient has got a type 1 diabetes, and we should not use this drug if the patient has got a lot of long or the late onset autoimmune diabetes in adults, so pregnancy, lactation. So these are the areas where we should not use this drug. Now, FDA has given this warning of acute kidney injury also, that we have to remember that this drug can cause acute renal injury. There is some concern of the bone fracture with the use of this canagliflozin. There is a concern of lower extremity amputation with canagliflozin, though there are a lot of doubt whether the canagliflozin or the SGLT inhibitor as a class is associated with increase in the lower extremity amputation or not, still a debated area. Now, the bladder cancer was basically another important concern which was raised along with the dapagliflozin molecule. So FDA has given some precautionary advice about the use of this drug in the patient who have a previous history of bladder cancer. Now, this is another important area which almost always faced with the use of SGLT2 inhibitor therapy, that is urinary tract infection, genital mycotic infection. My first advice is that those patients who have recent history of urinary tract infection, we should not use this drug, because that can precipitate another urinary tract infection. Genital mycotic infection is, on the other hand, is a benign condition, not like urinary tract infection. So you can ask the patient to use some antifungal agents and stop the drug, and usually it is very quickly reversible. So it is not a very important issue, but we have to keep an eye. We have to make the patient aware that the genital mycotic infection can occur with the use of the SGLT2 inhibitors, whatever SGLT inhibitor you are using, or also with this combination therapy. So this is a declared TIMI study which was published. It has included very huge number of patients, so we can have a very very good idea as far as the concern associated with SGLT2 inhibitors, and you can find that the diabetic ketoacidosis is an important issue as far as the use of SGLT2 inhibitor therapy is concerned, and also the genital mycotic infection is also a very important issue as far as the SGLT2 inhibitor is concerned. As far as the declared study is concerned, you can see that the other areas of concern like the amputation, fracture, the Fournier's gangrene, bladder cancer. This study did not show that there is any relationship of the use of SGLT2 inhibitors or particularly the dapagliflozin with these important issues. So basically, it boils down to two important areas where we should be very concerned and we should be very cautious. One is the diabetic ketoacidosis, and we should be very careful about that. And second is the urinary tract infection and genital mycotic infection, where actually these group of drug can cause some problems. So we should be very careful about these two areas, but we have to have some understanding that the other important area, the lower limb amputation, fracture, the Fournier's gangrene, bladder cancer, they are also an area of interest or area of concern to us. So whenever you write a drug, look into the prescribing information given by the company. Now, if you look into the prescribing information of the company or package insert by the company, you can see that they have highlighted the issue of pancreatitis. They have highlighted the issue of hypotension, because whenever you give an SGLT2 inhibitors, they actually reduces the volume from the body, so there is a possibility of hypovolemia, and therefore especially in some susceptible patients, say in elderly, it actually causes the orthostatic hypotension. So we should be careful about that. As I've told you, the ketoacidosis is another important concern in front of us when you give SGLT inhibitors, and as I've told you, genital mycotic infection is another area which we are very much concerned about. Now, this is another interesting understanding that when we give DPP4 inhibitor along with SGLT2 inhibitors, then the possibility of genital mycotic infection is less. I don't know. I have no I have no idea whether because many people actually doubt about this finding or this result, but it is still there. That the many studies has been done, especially by Rosenstock, by Diffronzo. So as you know that this study actually in combination, when we do a meta-analysis, we find that the combination therapy is associated with less genital tract infection. There is some explanation for this also is there, but you know though this data is there, that the many people have doubt as far as this data is concerned, or the implication at this area is concerned. Coming to the take home, the combination address multiple pathophysiologic defect, high efficacy, provides significant reduction in HbA1c and weight. The combination has very low possibility of hypoglycemia. Empagliflozin has got a cardiorenal protection and basically reduces the cardiovascular death and all-cause mortality. Linagliptin has got a proven cardiovascular and renal safety, and possibly it has got some benefit as far as the renal outcome is concerned. Just like other DPP4 inhibitors, we should be careful about pancreatitis, joint pain, and bullous pemphigoid, as because linagliptin is an important part of this combination. Empagliflozin, just like other SGLT2 inhibitor, can cause genital mycotic infection, urinary tract infection, dehydration, euglycemic ketoacidosis, acute kidney injury, fracture, lower limb amputation, and we should be very cautious to give this drug in elderly because of the postural hypotension. The contraindication of this drug is in pregnancy, breastfeeding women, type 1 diabetes, DK, EGFR less than 45, acute illness, and currently with urinary tract infection. Convenience of a single once daily pill along with potential lower genital mycotic infection with the fixed dose combination compared to a SGLT2 inhibitor alone is an extra benefit, if at all it is there, as far as this combination therapy is concerned. So thank you very much for your patient listening, and I'll give you the answer of the question which you have asked. So So the SGLT2 inhibitor and DPP4 inhibitor in liver cirrhosis, you know, the both the two drug has got a different you know, mechanism of action. So as far as the linagliptin is concerned, we can give it up to the moderate degree of liver disease. So you have to score the liver disease. The just cirrhosis is not the all issue. We have to score, you know, child who classification is there. You have to make a scoring. You have to see whether it is a mild degree of cirrhosis or moderate degree of cirrhosis or severe degree of cirrhosis. Now the DPP4 inhibitors, especially the this one is linagliptin, can be given in mild to moderate liver failure. Also the SGLT inhibitors. Is the heart failure benefit class effect of SGLT inhibitor? It is definitely class effect, no doubt about it. You can see that the heart failure benefit was shown with all three molecules, the dapagliflozin, empagliflozin, and canagliflozin. So this benefit is a class effect. And if you ask me, actually, my understanding is that the all the benefit whatever we see is basically a class effect. The benefit is not proven in the trial because of the fact that the trial design was different, and at the same time all the side effects what we see in SGLT inhibitors are basically also a class effect. It is not that canagliflozin only is associated with the lower limb amputation, nothing like that. So I believe that the benefits and the side effects all are basically class effect as far as these three important drugs are concerned. Now, how much is the combination effective in 3-point MACE? Now, the combination therapy, as I told you, the 3-point MACE benefit is basically on the empagliflozin only. The linagliptin has got neutral effect as far as 3-point MACE is concerned. So whatever benefit is given, it is because of the empagliflozin part only. It is not because of the linagliptin. But linagliptin is safe. It has got no any adverse effect as far as the 3-point MACE is concerned. Can a DPP4 inhibitor be combined with any other SGLT inhibitors? For example, remogliflozin with vildagliptin, both can be given BD dose therapy. Yes, you can combine. There is no harm in combining the two, but the issue is we do not have a fixed dose combination with remo plus vildagliptin. I understand this combination therapy will be very cheap. That also I understand, but there is a small but. As far as the glucose control is concerned, I have no doubt that this combination therapy will be very good. But if you are looking for cardiovascular benefit, if you are looking for the renal benefit, what I am talking about today, now whether this two drugs, the remo and the vildagliptin, has got any effect on the cardiovascular benefit, on renal benefit, is not known to us, because neither of these two drugs has underwent a dedicated cardiovascular outcome trial. But however, vildagliptin very recently have a very good study and very good meta-analysis, which is almost we can say almost confidently that the vildagliptin is not associated with any adverse cardiovascular outcome. So that way it is quite safe. But whether it has got any benefit, we don't know, because no dedicated cardiovascular outcome trial was done with either of these two agents. But as glucose control, well, it is of your choice, and both of these drugs are very good as far as the glucose control is concerned. Now, how can we manage a patient who are with SGLT inhibitor facing genital mycotic infection? Now, if the patient has got a genital infection, now there are two approaches. Now, if a patient can tolerate the amount of problem, if it is mild, you can ask the patient to take some antifungal tablets and continue with the SGLT inhibitors. That you can advise. And second is, if you stop the drug and give the antifungal agent within 3 days or 5 days, the fungus will disappear, and therefore the problem will be resolved. So you have two choice. If you have to talk with the patient, how big is the issue. Now, if it is a minor problem, you can ask the patient and can continue with the SGLT inhibitor and antifungal agent in combination, or you can withdraw the drug. Now, genital fungal infection is more with SGLT inhibitor when used in single medicine, but its incidence is less with used combination with DPP4 inhibitor. Is it a real fact? If so, the reason behind. Now, as I've told you, whether it is a real fact or not, that I have shown you, whether it is a real fact or not, it is doubtful. Though there are studies and there are reports and the meta-analysis also, and they suggest that the combination therapy is better as far as genital mycotic infection is concerned. Though I am not very sure whether the combination therapy will have this benefit or not. The reason proposed, the mechanism proposed is that some of the fungus actually use the DPP4 for their metabolism, and if you give the DPP4 inhibitors, this fungal metabolic pathway is blocked, and therefore there is a less possibility of the fungal infection. So I don't know. I have no. I have not studied, so therefore I should not comment whether it happens or do not happen. But we have the evidence, we have the data, and it is commonly said that if we give a combination therapy, the possibility is less. Is there any role of diabetes drug to tackle COVID-19 diabetic patient? This is a very interesting question, but I don't know whether any drug can cause there is no drug which actually can benefit COVID-19 till date as far as the evidence is concerned. So therefore, I must say that there is no any anti-diabetic drug as well, whether it has got any benefit in COVID-19. But having said that, I just would like to highlight that the hydroxychloroquine is a important anti-diabetic medication, which is actually has a DCGI approval as far as the use of the hydroxychloroquine among patients who are already receiving anti-diabetic medication as an add-on agent for the management of the diabetes or glycemic control. And as far as my knowledge goes, that this hydroxychloroquine had shown some amount of in vitro effect on the replication of the COVID-19 virus. So we don't know, we do not have any study, but nowadays WHO has taken up a multinational study to look into the 4 major agents which can have potential effect on COVID-19, and one of the arm is basically hydroxychloroquine. So unless and until the data is there, unless and until the evidence is there, we cannot say that the hydroxychloroquine will have a beneficial effect in the patient of diabetic who have COVID-19. So the use of LINA SGLT inhibitor in elderly where the renal function is preserved. Yes, you can definitely give LINA and SGLT inhibitor combination therapy in elderly, no issue. But we have to remember that when we give empagliflozin, it is associated with the volume loss, and because there is a volume loss, there is a possibility of postural hypotension. So as there is a postural hypertension, so this may be little bit unsafe in the patient who are elderly. So be careful about the postural hypertension, and be careful about the dehydration or the volume loss, and ask the patient to take good amount of water, and possibly you can use this drug in majority of the patient who are elderly with preserved renal function. To look into the eGFR, it should be more than 45. So I think I have finished. Thank you very much for your participation, and I'll end here. Thank you very much.